started from where we left yesterday, okay? So there are few slides that we didn't complete yesterday, okay?
Have we connected with the connected?
Yeah, it's recording. So yes, just towards the end, I was going to talk about potential complications, risk associated with the PA catheter insertion. Many of these are similar to what you might encounter, accessing, central venous circulation, basically, bleeding, mechanical complications, hematoma, hemothorax, pneumothorax, all of that. And then more with the PA catheters, risk of arrhythmias. So you might encounter atrial or more ventricular arrhythmias as you pass your catheter through the RV, especially if you don't get out of the RV quickly. You can have more arrhythmia, or patients have electrolytes, abnormalities, or acidosis. That's more likely to happen. We did talk about, the risk of right bundle branch block that can lead to complete heart block in patient with underlying left bundle branch block, and other, mechanical injuries from the catheter itself. Sometimes coiling or looping of the catheter, or if you have an AICD, so you have to be careful if patients have AICD in place, that your catheter might loop around the AICD wires, or trying, to pull the catheter out. Sometimes it might tangle around the wires of the pacemaker. So be, mindful of that. And of course, the inaccurate measurements and misinterpretation of the data, which is, the biggest issue, with the PA catheters. So to summarize it, the pitfalls, like I said, and we discussed that yesterday, is importance of putting your transducer at level to your phlebistatic axis, which is the we did talk about how to troubleshoot your system that can get dampened from air or from kinking or other issues. And we did stress the importance of getting your measurements at the end of expiration, whether patients are breathing on their own or if they are on positive pressure ventilation. And then, some difficulties, wedging that might have to do with the right ventricle or the right cuspid valve or intrinsic pulmonary vascular disease. So we did cover, the indication. We said that there isn't universal, accepted indications, but there are common ones that you can justify putting the catheter for. So you want to make sure that whatever you're trying to achieve by putting your method, and you want to make sure that what you get is valid and accurate, because if you don't, you can apply it in a harmful way to your patient. And you have to look at the numbers, whatever numbers, always you want to make sure that it adds up and it makes a clinical sense. So it should correlate with what you see, with your eyes on your patient's exam, their x-ray, their labs, and others. And the other thing, you want to get your catheter out once there is no further need for the catheter. And like I said, we've seen patients developing, bacteremia with the catheter being left in place for a few days. And there is incremental risk of infection, the longer the catheter stays in place, there is higher risk of infection happening. Okay, but the catheter, nonetheless, regardless of all the controversy, is very powerful mean to monitor the cardiovascular function at the bedside. You can gather a lot of information, and we discussed what you can get from the catheter with the direct measurement and a lot of calculated parameters that you can derive from that. But there is inaccuracies with the measurement, there's misconceptions, like I said, and more so with the poorly documented benefit and potential harm from the catheter. You do need to have very good understanding of physiology, pathophysiology, underpinning for you to be able to gather your information in an accurate way, and more importantly, to apply it to your patient in the right direction. So that's to finish yesterday's talk, and I went over this diagram, and it's important, that's showing you your cardiac cycle. At the top here is the aortic pressure, down here is the left atrial pressure, and down here is the ventricular volume. Here is your EKG, and these are the cardiac sounds. So you have the different phases of the cardiac cycle. You have the atrial systole, where you have depolarization of the right atrium, giving you the P wave, and that corresponds to the contraction. So when you look at your CVB, the C wave, which represent the atrial contraction, comes after the PR interval. And here you see increase in the left ventricular volume during diastole, and you have additional increase with the atrial kick towards the end of ventricular diastole. And here is the beginning of the left ventricular depolarization or contraction. And you have the phase when the volume in the ventricle is the same. So all the valves are closed here, the mitral, the aortic, pulmonic, and tricuspid valve. And as the pressure increases in the left ventricle, it will exceed the pressure in the aorta, and this is where your aortic valve will open up, and that's the ejection phase. So the blood comes out from the left ventricle, and that's the end of the contraction here and the relaxation. So this is the drop in your left ventricular volume. So this is the end systolic volume, end diastolic volume, and the difference is the stroke volume. So that's basically the cardiac cycle. So, but we'll go through some questions here. And like I said, these will be things that you might expect to see showing up on your board exam. What do you say? Yeah, this one, yeah, he's smart, right? Yeah, he's smart. He got all the, yes. So, yeah, but I think you're going to do better than this guy, right? On your questions. All right, we'll start with the easy one for Mahmoud. Since he's the first year, we'll give him the easiest question. Yes.
The following is a true statement regarding placement of PA catheter. Advancement the catheter slowly through the RV. We inflate the balloon before retracting the catheter. C, once a good catheter tip position in the proximal pulmonary artery is achieved, it's likely to migrate distally. D, be aware of using PA catheter in the presence of left penetration. Oh, this is wrong, I know.
Looking for the correct answer, right? Yeah, no, it's yours. It's your name on it.
What is it true?
Yeah, it says that.
Okay,
What is
sorry,
it?
I got it the opposite.
Yeah.
All of them is wrong, only one.
Okay. This is the true one.
Which one?
The last one.
Last one. Okay.
So that is the contradiction.
Very good. So we said you have to get out of the RV quickly, right? And as you advance your catheter, the balloon is inflated. When you're good possibility that the catheter can migrate even after you place it in a proximal position. There is, tendency for the catheter to distally migrate. So you have to be careful. And we said that you check that by looking and seeing how much it takes volume, to get you in a wedge position. If it gives you a small amount of volume, less than 1.25, it means that you are out, you pull your catheter and you're inflated to make sure you get the full volume to achieve wedge position.
This board, because they get like a EKG with complete heart block, and they will give you the
Options.
Back to pacemaker,
Right.
Inflate the balloon, and the question is just to distract.
Right.
That's the question.
All right, so we'll ask Hamza, his second year, to tell us what's happening here. So we got an EKG, we got tracing here from a PA catheter, and they're asking about what happened here, moving from here to here.
Where you are in the
Right, where are you positioned on the left side and where you are right now?
The EKG is up, so the systolic.
No, I mean which part?
What waveform here? What waveform you see here?
This one?
Yeah.
This one is the PA.
Okay, and this is the PA because
Because you have
okay, so you got the diacritic notch. This is systolic.
systolic and diastolic.
This is diastolic. Okay, and the next
And
one,
the diastolic is up.
right? Oh, sorry. And the next one.
I think this one is which, right?
Okay, so what are these waves here?
No. So I think it's RA.
RA. So you're going from the PA to RA.
That's reflecting from the.
So, pulmonary cavity.
No, so you are wedged, right? And you got the A and the V wave, right? Now you can't go from the PA to the right atrium without going into the RV, right?
Yeah, that would be.
Yeah. Now you can loop back, between RV and RA, or yeah. But that's a wedge. That's an A. That's a V wave. So you are in the wedge position on this one, right?
What's wrong with the wedge?
Right. I mean, that's
Yeah, why
The
does
wave
it look
is
like?
big, right?
Yeah, why does it look like this? That's the other question.
so. That's the normal V wave is not that big, right? And we did talk about differential diagnosis of big V waves. So what was the all of these will right, and this can be confused sometimes if you get a large or tall V wave that you might think that you are still in the PA position, and you might keep, advancing your catheter, and you will end being, very distant out, and you can potentially rupture pulmonary artery and cause massive hemorrhage. And it's another complication I didn't mention, but it's a big complication which can be fatal. And the way to recognize that is to look at the relationship between the V wave and the T wave here. So it will be far out in the cycle just before the P wave, compared with the systolic of the PA waveform, which comes earlier in the cardiac cycle. But that's something that it's called mitralization. So it's potentially something that can be confused as if you are still in the PA position. So you have to recognize that.
If you get a board question with the BA catheter, it will be this question. Like if you giant V wave after wedge, and like the answer is either mitral regurg or VFD.
Yeah, right.
So that's 100% about.
So we got one question guaranteed.
That's a complete question in pulmonary and critical care. Giant V wave after.
Yeah.
That's,
They throw
Out of 300.
that question.
That question.
Mhm.
The person has-
You're gonna bring it in.
Where's Katabi? Katabi gave a presentation about this, but we'll ask Yunus to. It's an easy one, right, for you, Yunus. Third year, it's easy for you.
Which measurement is? Patient is septic shock with hyperventilation, central venous pressure, pulmonary occlusion pressure. These are static measures.
Static measurements, and we talk about, what are the pitfalls with this, and yesterday, right, as far as volume status, cardiac status, they don't truly reflect, what was going on. Okay. About the mixed venous saturation.
Septic shock, no, sometimes it's high. So
Okay, so we can't.
Doesn't give you if it's not too responsive.
Right.
Dr. Zeid asked about
Yeah.
D. He said like the
Yeah.
expense options
what-
what's about it? Why did they put it in here, and how does that have any relation with
So in hypovolemic shock, the mixed venous to differentiate cardiogenic from hypovolemic, the mixed venous is low.
Cardiogenic from septic shock.
Right, so a surrogate for cardiac output,
Yeah.
and
Or this-
not a septic patient, but someone, with cardiogenic shock.
would be low.
There would be correlation based on the fixed equation, the lower SVO2, the lower cardiac output. Doesn't apply to sepsis, right, because of utilization, peripheral utilization. So you can have, falsely normal or high SVO2, in the presence of shock, especially when patients have the hyperdynamic phase of the septic shock.
Regarding the pulse pressure variation, just a few limitations that you can't use. Like for example, in patient with atrial fibrillation, you
Right.
have like patient in sinus,
Right.
passive, not active on the vent, and
Large
patient-
tidal volume.
large, like
Right,
8 ml per
right,
kg tidal
right.
volume.
Yep.
So you pulse pressure variation in the patient on mechanical ventilation, you need them like passive, not taking any pressure, any volume, and good tidal volume, 8 ml per kg, and in sinus rhythm,
Right.
not in.
Right.
as what Katabi said?
Right. So, yeah, because the AFib, you can have variation from the rhythm. Okay. All right. Let's keep the momentum.
Ramsha, she looks like she.
Yeah, she's going to answer this one. Yes. Yeah. Yeah, we've covered all of these. At least, we went over them. So just.
After raising a swan dance catheter, check the pulmonary artery oxygen pressure frequently. Withdraw catheter slightly if pulmonary occlusion pressure waveform is obtained with inflation less than 1.25 ml air. Advanced pulmonary arterial pressure catheter slightly if the pulmonary arterial occlusion pressure waveform is obtained with inflation of less than 1.25 ml of air, or always use 1.5 ml air to inflate the balloon for a pulmonary arterial occlusion pressure.
It's a big complication, right? And rupture of pulmonary artery, massive hemorrhage, like I said, it can prove fatal. So, not to take PA catheter, placement lightly. So
Check it frequently.
check frequently, probably.
Draw it, because if it takes
You
a
run-
small amount of air,
Right,
then
right,
you're too far.
right. Remember, when you put this one, you put it in a proximal position, right? And we'll show you example of the X-ray where it should be, medial to the descending part of the PA catheter. And even before you take your X-ray, you know that you are in not a distal position by seeing how much it takes, by putting air in the balloon to achieve the wedge position. And if it takes, less than the full amount, it means that you are out and you slightly retract and you're inflated again. But that's the idea from the question. All right, Katie, the next one.
8-year-old woman postoperative from neurosurgery with shock and hypoxemia. Parameters. Okay. So arterial blood pressure is 80/45. O2 sat is 87%. Right atrial pressure is 20. O2 sat is 44. RV pressure is 50/20. Sat is 45. Pulmonary artery wedge pressure is 50/25, 44%. Sorry, pulmonary artery pressure is 50/25 with 44. Wedge pressure is 10. Cardiac output is 2.4.
Okay, so before we go to the options of the answer, what do you think? Is this profile? So what's this profile? What does it consist with?
I think the Roche vision is not 12, so most likely.
Just look at the whole number. Don't look
Yeah, yeah,
at
just,
Look
yeah.
at the diastolics,
Yeah.
it's still like,
Yeah.
why, like, doesn't look like each other, no.
Right side, basically.
Okay, so your RA is high, your RV is high, your wedge is high,
Cardiac output.
your wedge is normal,
Yes.
your index is low, right, on the low side, and then patient is hypoxic, and they're giving you the clinical context, right? So you take PE, and it has to be a big, massive, submassive PE, and that, okay, and then knowing your profile, you'll be able to spot your answer, right? Okay. Yeah, okay. All right, so the
64-year-old man with acute myocardial infarction is immediately before V6, shock in your lemon. Hypertension, right atrial pressure 10, right ventricle 50/10, pulmonary arterial pressure 50/30, pulmonary pressure 26, cardiac output 1.6. Just go with the,
so what's the profile here, the hemodynamic profile consists?
it's hypotensive.
Okay, so you get
it's
shock
decreased
state,
cardiac
right,
output.
someone with an MI,
Yeah, MI, so cardiogenic moment.
I get murmurs, so some sort of mechanical complication of MI, okay.
Yeah.
So you get high wedge, get high RV,
Pulmonary arterial
RV.
pressure is 62% that's sad. It's more than the right atrial pressure, so there is maybe some shunting.
Okay, so you see some step up of the saturation, right? And that consistent with what will be the, okay. So that used to be common, maybe not so these days after, thrombolysis and the PCI with usually anterior MI, 2-3 days into the course of the MI, patients might go into cardiogenic shock with this picture, so that goes with the new murmur from the VSD and the step up. And when you put your waveforms, so this would be an example of seeing large V wave on your wedge. Okay. Let you do the math here. You're good in math, right?
Excellent.
All right.
Cardiac output.
Put your skills to work.
Nerve 60, right, arterial pressure 10, wedge 20, PAP 30. What is the calculated systemic vascular resistance? Excellent. So it is MAP minus
So then what's the
wedge,
equation? So resistance?
like yeah, it's the map minus
CVP.
60 minus.
Yeah, do it. Oh, yeah, you do it.
Shaheen, guys.
He is a
He's the one
senior.
who's answering the
He is
question.
going to graduate in a few months. And he will kill it on the board, right? He will,
Guys,
yeah, okay.
uh,
so what's the equation for the
For resistance.
systemic vascular resistance?
it is the pressure gradient divided by the flow, the cardiac
Good.
output.
Yeah.
So the pressure gradient, isn't it the pulmonary artery pressure minus the weight?
No, you're asking
that's
about
the TPG.
systemic.
That's it, the TPG.
It's
Okay.
asking about systemic vascular resistance. So what's your upstream, what's your downstream pressures?
The CVP minus the map minus the
Yeah,
CVP
yeah.
divided by the cardiac output. So it is 50 divided
Map is
by
60.
yeah minus
Minus 10.
10.
Oh.
50 divided, it should be 50 divided by 5.
Equal.
That's 10,
10.
right? That's the wood unit, and then you change it to the
Times 80, right? So it
Uh-huh.
will be 800.
800, okay. And for PVR, it will be mean pulmonary artery pressure minus switch.
30 minus.
You know, it's different pressure. The flow will be the same, the cardiac output, and then you get either wood units or you get
This is actually like a
the-
board question,
yeah, yeah.
like this,
Come on,
and
guys.
compliance,
Right now.
the compliance and
And
this
resistance.
resistance, this is also guaranteed.
Yeah, okay, but that's your equation here. Like I said, the Ohm's law, resistance flow of pressure overflow, and then times 80 gives you the down units. All right, go to Hamza maybe for this one.
If there is wave, it's Hamza.
Yes.
I'm here for
I'm
me.
trying to keep Mahmoud from the hard questions. Just
Thank you.
you get an RV and LV pressure. So this is LV here. You remember yesterday when we talked about tamponade versus constrictive pericarditis on the waveforms? Just guess which one it might be. So the clue is down here, right? Here.
This is the concept.
This is what we call dip and plateau. This is square wave. And that's something you see with constrictive pericarditis. Okay, you see elevation in the pressures, equalization, but you see this dip and plateau. So it's something you see in constrictive pericarditis from an infection, post.
That will be your board.
Yeah, post radiation. Yeah, that's another board, but that's it. Okay, so it's right and left heart catheterization. This left ventricle, right ventricle. Again, this is what we term it dip and plateau or square waveform.
Remember,
Restrictive pericarditis, those, so you can see it with restrictive cardiomyopathy and with RV ischemia.
If there is a lot of movement in
Yeah.
the ventricle itself because of constriction from
Right, because
outside or from inside,
Yeah.
like inside, it will give you this
Yeah,
dip with like equalization of this diastolic
Right.
together with the right
right.
and left
And the other thing you see is, you remember yesterday we talked about the Y descent. So the Y descent would be, no, it would be exaggerated with the constrictive pericarditis. It will be absent with tamponade because you have pressure around the heart. It prevents, the blood from, going from the atrium to the ventricle. Yes, Katie.
That was my question.
Oh, okay.
If,
Yeah,
the-
yeah. All right, Mahmoud.
68-year-old woman with acute myocardial infarction, ST elevation V3, V61, lead 1 LVO. Parameter arterial blood pressure 82/55, which is hypertension. Right arterial pressure high 20, right ventricular pressure 30/20. Pulmonary arterial pressure 30/18. Pulmonary pressure high, cardiac combat is sedating.
So what's the profile consistent with?
Left side. It's,
Yeah, it's a shock, it's a cardiogenic shock, right? I mean, these are all examples of cardiogenic shock, right? Okay.
Pressure high, cardiac output.
Okay, what else do you notice on these numbers here?
Venous gas less than 60.
Well, I mean, it goes with the shock, right?
yeah,
Okay, how about the pressures here, right?
Yeah.
Right, I mean, they're close, almost close to each other,
Diastolic and pulmonary wedge.
right, which goes along with tamponade. So,
Does that go with definition, like, if you don't mind, like I said, if you go back to the numbers?
Yeah.
Does that go with the definition for cardiogenic shock in this patient? What do you think? Like, if there's a board question and say this is a cardiogenic shock definition.
You need cardiac index, I don't know.
yeah, you got
Yeah.
cardiac output
Yeah.
2.2, yeah.
The cardiac index is
For sure,
higher
cardiac
than-
index will be less than.
Oh, yeah.
Yes.
Okay.
yes.
Yeah, that's it's a right, it's cardiogenic shock. Hypotensive, low cardiac output.
Mhm.
Complicated MI, right? Mechanical complication, which goes with this, right?
Cardiac rupture.
Okay. All right, and that's just depiction of what you see. So near equalization of the pressures, and so the elevated pressures with equalization, and again different from constrictive pericarditis, you have a blunting of the Y descent here. And that has to do with the pressure outside in the pericardium, attenuating the blood flow from the atrium to the ventricle. Okay, that's again just to stress that point. So difference between what you see in tamponade here, that's being normal, and here you see the blunted Y descent. And that's again, the difference between constriction, again, keep that in mind. The paradoxical pulse, you see it with tamponade, but not with constriction. Equalization of pressures, you see it in both, of course. The wave morphology, the Y descent is absent in tamponade, it's exaggerated or prominent in constriction. This is the cosmal sign, the inspiratory change in systemic pressure is increased with constriction, decreased here. And then the example of the square wave or the square root sign, the band plateau is there with constriction, but not with tamponade. Okay, next, Yunus.
A chronically ill patient admitted with present requiring shock, fever, pulmonary infiltrates respiratory failure by arterial line. BP is 105/45 on admission. Now it is 75/60. Dual birth form on display. So.
We are graduating as well.
Oh, he will, he will get this one.
I think it is over.
Overdone.
Okay, so what makes you think it's overdone?
Because it is a small, I don't see the.
Like,
notch.
Right.
What is the most accurate thing that you can say? It's like why for 100% is overdone? It's not the decorative notch. Sometimes it's
Because
the
the square disc, there's no oscillation.
Right.
That's right.
There are 2 and 3
So
oscillations.
no oscillation,
And
you
it's
got
gonna be, the diastolic gonna be over.
Diastolic is 5.
overestimated. So you got narrow pulse pressure, low systolic, falsely low systolic, high diastolic, and pulse pressure.
So
is-
the map is lower or higher than normal here, Eunice?
Map,
Yeah, what do you think?
map shouldn't change.
Should be
Awesome.
good. Map is preserved, right? But nonetheless, you have to.
They're all ready for the exam.
Yeah, he is. So what do you do here? Troubleshoot, right? And you do that with your flush test, right? Or square rapid flush test. So this is what you do. And that will be the normal. And this would be the
I think
underdamped.
that lower, yeah.
Yeah, that's the normal. This is the underdamped where you see excessive oscillation and absent oscillation when the system is overdamped. And that's normal here. Once you flush it and take care of the problem, you start seeing normal morphology of the waveform. And you see the oscillation here. Okay, but we did talk about, natural frequency, resonant and tendency of the system, to dampen as the signal is transmitted from the patient to your monitor. So that happens, and this is where you want your system to be optimally damped. And you check that at least once every shift, or if you have, concern about your measurement, of course you have to check it, but that's the rounded appearance of the waveform. And when it's underdamped, and that has to do with lengthy tubing, or the tubing is not stiff, because it has to be stiff. You can see overestimation of systolic, underestimation of diastolic with multiple oscillation, but again, your mean will be normal.
Sometimes the nurse will come to you and say,
Yeah.
hey, the systolic is good, but the mean is low. Can we just go with the systolic? And you go over the monitor and you see it's underdamped, and the systolic is good because it's underdamped. But not
Yeah,
because
give you
it's
higher
good.
systolic.
That's right.
Right, okay. Next one. Yeah,
Assumption.
yeah,
Okay. Median history of diabetes, hypertension, and renal transplant. Presents clearly after being found unresponsive at home. Temperature 37.3 is high. Blood pressure 71, hypotensive, tachycardic, tachypneic, hypoxic, 70% of glomer. Exam reveals bilateral rails. S4 is present, no murmurs. He's intubated for error prediction, and he shows signs of tachycardia with left bundle branch block. P catheter is inserted, and values are as below. Right urine pressure is high.
no, and it's not high, right? I mean, it's high. It's still within the normal.
Pressure is- that's-
Yeah, what's the normal RV pressure?
Yeah,
25.
Yeah, I mean, it's 25, right? Maybe up to 30, okay.
Yeah. Pulmonary artery pressure is high, occlusion pressure high, and cardiac output is okay. Cardiac index,
So back to the stem of the question here, what they're describing.
patient is-
It's like heart failure.
Right, pulmonary edema, heart failure, someone with hypoxic, got, risk factors, got crackles. And then looks like there's a new left bundle branch block. So here you're going to put this one again. It's where you have to think about putting this one, have to be careful, right? Someone with left bundle branch block. Now, the numbers here, and I'm not sure, about the source of the question. I have to remember where I had this question. So your wedge here is higher than the diastolic, right?
So good that reading.
Right. I mean, doesn't happen often. It might happen, in few situations where your wedge can exceed your PA diastolic. This won't be the typical. So, yeah, keep that in mind here. Okay, so what they're asking about here.
this is the left bundle branch block. Although
Yeah, which goes with an MI, right? I mean, if it's a new onset, we don't know. I mean, they didn't say if it's a new left bundle branch block. They didn't say about the troponin, but nonetheless, they throw the hemodynamic on you, and they want you to choose what would be the best treatment based on what you think is going on with the patient, right?
Someone said is there any chest pain? This patient has chest pain.
She can talk, okay. What do you think about the answers? And again, there could be some talk about,
But I think in real life, you would do like a stat bedside echo.
right.
How that will help you.
For a treatment, I think for,
So before you found the
yeah,
pulmonary
for a
catheter.
treatment.
yeah,
Right, they didn't say PCI, right? So they didn't say PCI. If they said PCI, yeah, which you expect, this is something that you do, someone with suspected MI, you take them to the cath lab and you'll be ready to intervene, right? But they didn't do it. They give you the TBA here, assuming that patient is not in a place accessible, for.
Yeah, that's
left
the
back.
issue, like more the question
Right,
sometimes. will
right.
give you
So
the
it
time.
does not
For example, it will give you
necessarily,
like 2 hours, maybe.
Yeah, you don't want to overthink your answers, because if you do, sometimes you find yourself picking not what they are looking for.
But then sometimes like you need, for
Yeah.
example, the cath, take him
Yeah.
to the cath lab or
Right.
give him the TPA. You need to know what
Yeah,
time
yeah,
or how accessible
right,
it
the
is.
time window, right?
Time to door,
Yeah.
door to needle.
Yeah, door to needle
Door to needle.
or door to. So here probably would be a TBA, I'll say,
No, he's not, not this one.
No, not this.
That's old, very old.
What was that?
That's
That
You're
patient
on
was
the
the patient was discharged.
What was it?
Katie, she left when
like, her mind-
Your first question,
Employment behind.
your first question was the neurosurgery guy, and that was discharged.
We'll get you another refreshing question. Okay, but that's your hemodynamic profile, right? And shock, the most common type of shock, which is the most common form of shock. Distributed, right? Distributed is the most common. Low here, high in cardiogenic shock, in septic shock, depending on whether patients are, volume resuscitated or not. It could be low, it could be normal, but the output will be high with the distributive shock. This should be low, sorry, they put it, this should be low. And then the SVR will be high, and will be low here. See, get you a good question, Kitty.
Okay. The static axis for response to the force in the fossil space mid. And to be placed above the 0 point.
above and this.
So it's. It would underestimate?
Yeah, really the opposite. Remember yesterday we
Yeah,
said
above and-
leveled, if you take 1 millimeter mercury, 1.36 centimeter H2O, but you can really make a big difference, placing your catheter above by like 10 centimeter, that can falsely lower your wedge by about 8 millimeter mercury. So you can, miscategorize your patient if you're looking for someone with pulmonary hypertension, depending where you place your pressure transducer, whether it's leveled correctly or put above or lower where it should be. But it's the opposite. When it's higher, it's underestimated. When it's lower, it's overestimated. Okay, that's just the example here. 12 millimeter when you are leveled correctly, 10 centimeter above gets you down by 8. So bringing you falsely to 4, or higher, by 8, bringing you up falsely to 20.
And now with the definition, the new definition of pulmonary hypertension and wedge and all this, things like these change.
What measurement you ended getting? All right, Saddam is
Central venous pressure is
easy one also.
intravascular volume, venous tone, right ventricular compliance, intrathoracic pressure. Get everything.
Everything, right? We talk about limitation CVB, right? We said it's not measurement of volume, it's not measurement of cardiac function. There's a lot of external factors, whether in the chest, the pleural pressure can affect it, whether it's in the abdomen, the intra-abdominal pressure can do the same thing if patients are on pressors. If you're, pulmonary venous capacitance, or you have pressors applied, you can increase your venous tone, and that can bring your CVP higher. And so it can be very misleading if you rely or if you go with the CVB to guide your fluid therapy. Good. Anthony.
Which of the following statement is correct concerning positive and expiratory pressure and left ventricle preload? The measure occlusion pressure is artificially decreased by PEEP application. The transmural LV pressure is decreased by PEEP application, measured of the occlusion pressure after 1 minute of PEEP disconnect would provide a clinically useful estimate of LV preload. The application of PEEP increased LV preload.
Okay, let's go over them one by one. Start with the first. statement. What do you think about the first statement?
Occlusion pressure decreased by PEEP. It should increase because the people increase the increase intrathoracic pressure. Will decrease the preload.
So the wedge is like the CVB, right? It's subjected for the effect of the
Yeah.
pressure in the thoracic cavity,
Mm.
right? And that depends on the lung compliance, how much PEEP you are applying to your patients, some of that can be transmitted to your alveoli. And again, it has to do where's your catheter is located. I don't think we talked about that yesterday, but the waist zones, get zone 1, zone 2, and zone 3. Where do you want your catheter to be? What would be the ideal position of your Swan-Ganz tip? Which zone? So zone 3 is the lower zone, right? So you want it to be in zone 3. Zone 3 this is where your vascular pressure, your arterial pressure more than venous, more than alveolar pressure. So if patients are hypovolemic, if patients are on excessive PEEP, you can increase your zone 2 and potentially zone 1. So your catheter can be functionally in a zone 1. And in that case, a lot of the PEEP can be transmitted to your catheter and you end measuring, alveolar pressure instead of vascular pressure. So the first question would be wrong, right? Because it artificially increase your PEEP, your wedge pressure, again, to a variable degree, depending on the factors that I discussed. How about the second one?
What's transmural pressure, Anthony?
It should increase.
What is transmural pressure?
It is the wall tension wall pressure, right?
So
It should increase by increasing PEEP.
So when someone comes to you with pulmonary
Because
edema, right?
increasing the intrathoracic pressure will increase the tension wall.
So it's the
Maybe,
difference
right?
between the intracavitary pressure and the pressure outside the ventricle. So when you apply PEEP,
And that would transmit to the left ventricle, left atrium, and to the wedge pressure.
The pressure difference between inside and outside the left ventricle.
is this
Does it
transmitted?
increase or decrease with the PEEP application?
So meaning patient would,
It should increase.
so when you have a patient with edema, cardiogenic shock, and you would apply
Mhm.
PEEP to them, what's the idea of putting them on PEEP?
Decrease
the preload.
That's one.
And after
and decrease the
You unload the left
preload.
ventricle, right?
Yeah.
And you unload it by decreasing the transmural pressure. So decrease the transmural pressure, right?
Mhm.
Okay, how about stem C? You take the patient of the PEEP to measure, to get accurate
No,
measurement.
No.
What will happen if you do that? They will desaturate, right? They will de-recruit. They will de-recruit, right?
Yes, yeah.
Okay. I mean, it was something, proposed in the past that, to get accurate measurement, briefly disconnect the patients to eliminate the effect of the PEEP, but you see patients. And that does not reflect the actual measurement because, the patient, they are on PEEP. So what you get of PEEP measurement is not going to tell you what accurately will be the situation when patients are put back on the PEEP. So, and the last one,
No.
we said it decrease, right?
Decrease. Yeah,
Right.
it will decrease.
Right. So the right answer is B. So the
Transmural pressure.
Why is it wrong? Because when
It decrease.
Decrease.
Decrease
You decrease, right?
preload. It will
You
increase
decrease venous return.
So when you have PEEP, do you increase your pulmonary flow or decrease pulmonary flow?
Right.
When you have PEEP. You have PEEP, you have more vasoconstriction around the alveoli and the blood vessels, is that right? And that will decrease the next cycle, which is the preload to the left ventricle.
preload to the right
left
side
ventricle.
decreases.
Yeah, to the left side.
To the left side.
Yeah, I know.
Now,
But the
depending on the level of the PEEP, you can potentially cause decrease. You increase your vascular resistance, so you can potentially decrease your RV outflow of your RV stroke volume.
Yeah.
So it can be harmful, the PEEP in an excessive, and that's something happens in patients, with massive PE. When you put them on positive pressure ventilation, patients can crash because, you increase the intrathoracic pressure, you constrict their vessels, you increase, the afterload, to the right ventricle, and patients might be marginal, then they can decompensate. And patient, often develop, hypotension, and we've seen patients, arresting, on the-
failure need low P.
Right. So the RV failure, you want to minimize volume. You want to protect your right ventricle by, minimizing the PEEP, or if you can get away without positive pressure ventilation, that's even better.
Just remember that PEEP is not good for the right side if you want to think about it. But
Yeah, yeah.
And left, it's good for the left side.
Exactly.
And it actually increases preload. The reason why, and you need to know why the physiology difference is on the left side, left ventricle, it improves cardiac output because you're increasing preload and you're decreasing the transmural pressure, you're decreasing systemic vascular resistance. So you're decreasing resistance and you're increasing preload, so you have improved cardiac output. The reason why the preload increases on the left side, decreases on the left side, LV preload, decreases, is because you have increase in peripheral vascular resistance because of the PEEP. So that's why you have decrease in contractility of the right ventricle. So you've got less blood going into the left ventricle.
Yeah, same thing. Yeah, same thing happens with the volume. If you give volume for someone with RV, impending failure, you distend the right ventricle, and then you cause, the bowing of the septum, and then you compress your left ventricle, so you impair, the left ventricular filling. But yeah, as Dr. Jasmine said, the PEEP has salutary effect on the left ventricle. It unloads the left ventricle. It improves your forward flow, so it's good for the LV. No, it shouldn't be here. I'll explain to you over here. Here. This is your wedge.
Okay.
Your swan wedge. This is one wedge. This is the pleural space, and this is with the alveoli here. And this is here after you apply your PEEPs or your transmural pressure. Here, if you have 0 PEEP, your pleural pressure is -2, right? Normal. So your transmural pressure will be 18. If you apply PEEP, you're going to decrease the difference. Your transmural pressure will be down to 12, right? And this is what we do for patients with O2 PEEP, right? So it's another somewhat unrelated, but with O2 PEEP, you apply external PEEP, so you decrease the pressure gradient that the patient has to generate for the ventilator, to sense their inspiratory effort. Okay, we did talk about this, just showing you example. It might show up. We said that your measurement should be at the end of the expiration, so the spontaneous breathing, and it will be the opposite of in patients on the vent. So during inspiration, you see lower pressures here, so your measurement should be towards here at the end of expiration. Okay, go back to Hamza.
A 56-year-old white female with history of breast carcinoma treated with modified radical mastectomy, radiotherapy, and chemotherapy, presents to ED with subsequently to ICU with BP 32/50, pulse 120, cold clammy skin, with shock and tachycardia with increased vascular. Okay. Volume infusion is informed and flow directed pulmonary catheter is inserted. The tracing obtained during RV catheter transient is shown below.
Let's see if it's there. Okay. Yeah, so here, I'm just want to show you the flow here. So that's
the deep. This is the
the band plateau of the square, right? Okay. All right. So once you identify that, you'll be able to. Right. So the patient has had radiation. It looks like she had developed, radiation pericarditis with restriction, causing the
questions that will save you time.
Yeah.
See the.
see that
Go to. Don't think. If you think you will.
No, but you can think about it also from from physiology standpoint here. So that's your LV, your RV, and again the pressures are equal, and then the square. Okay. So again, the right heart catheterization.
equalization.
Yeah, equalization. Okay, Mahmoud, back to Mahmoud.
The first part of this tracing measures pressure in
So we did another question in the opposite, right? So I think about it in opposite way.
It is
It's somewhat tricky, the question is somewhat tricky in the way that they
So
put
that's
the,
the PA and then, right?
okay, so on the left side, what do you see here?
It's compatible with systolic.
Okay, let's start on the right side here. What do you see on the right side?
Look at diagram, much.
So that's PA, right? And here you have two waveforms here, right?
Systolic and diastolic, it's gonna be
So
all
you
big.
got A and J and V, right? So that's this one inflated wedged. This is okay. So the wedged reflex, which and from these four answers, what would be the most accurate one?
The wedge reflect left atrium.
Left atrium, right? Right. And we talk about limitations as far as measuring the left atrium is a surrogate, it's indirect measurement, but have to take in consideration whether patients have mitral valve disease, whether patients have intrinsic pulmonary vascular disease, because all of that can cause discrepancy between the left atrial pressure and the wedge pressure.
If you go down from the
You're gonna
QRS
go from
complex,
left to right or
from
right
the
to
QRS complex down, it's the A wave.
Right, yeah, that's the A
will give
wave.
you- It's
Right.
the left atrium.
And the V wave comes later in the cardiac cycle, just in the TP interval.
Because the
The
right atrium will
Yeah.
be at the level after the B wave on the
Right.
EKG.
Right, it comes later for the LL, later in the,
That's at the level of the QRS, so it's left atrium. It's a left atrium, not right atrium.
okay.
Because the A wave at the level of the QRS, so it moved.
That's the normal transition, when from the PA to the wedge. And if you have, mitral regurg or other conditions, it will be a taller V wave.
And how did he get these? Like, it wasn't the witch then?
Right. Then then you deflate your balloon and then you get back in. Right. Okay. But that's, with what we call the giant V waves. And okay. And again, that's your waveforms, what Muhammad was talking about, as far as your A wave, which represents the atrial contraction after atrial depolarization. Yeah, so that's in the PR segment, and you see at the beginning of the ventricular systole where the tricuspid valve bulges in the ventricle, so it corresponds to the R wave. Systole, so you see the X descent, and your V wave, which is filling of the left atrium, comes after the T wave. Now, on the left side of the heart, we see the electrical events precede, but then there will be further delay in the waveform, so things will be moved to the right side. So you see your A wave comes after the QRS, and your V wave will move further out just before the P wave. Okay, we'll do this, will be the last question. Yeah, Yunus, is for you.
Which modulation continues slightly high. A is low, B is if it's normal, C is high. As the curve is smaller, the cardiac output will be higher. So
Okay.
C, I would say C is the answer.
Okay, and you're right. You remember we said the thermal dilution is one way to measure that gives you, there's computation, and then you get, three curves, and the three curves have to be consistent, close to each other. But the smaller the surface area underneath is, the bigger is the cardiac output. These will be the shapes, the normal shapes for the cardiac output. And that has to do with the equation here. Okay, so that's the equation of calculation, and has to do, with the temperature difference, which has to do with the flow. So it's a function of the flow, which is the cardiac output. But that's how the low cardiac output will appear. So bigger surface area, opposite for the high cardiac output. That's the normal. And we did say that there is limitation. If patients have tricuspid regurg or VSD, you can't rely on thermal dilution, because the blood will regurge back to the atrium, and this is how it will look like on the from tricuspid regurg. So you see the curve extended and flattened. All right, we'll do this last one.
Left ventricular end diastolic pressure.
So there's LVEDP, there's LVEDV, which is the volume. And sometimes you measure the, especially if patient goes for simultaneous left and right heart cath. So it's very useful to get, the accurate measurement of the left ventricular and diastolic volume. In some patients, you may not be able to get a wedge or accurate wedge, so you rely on the LVED volume instead.
So the preload?
Yeah.
On that,
Tell you about the preload because it has to do with the compliance of the left ventricle. So you can have certain amount of volume at the end diastole in the left ventricle, and your pressure will be high because the ventricle is tense. Therefore, because you have a lot of pressure from outside, from being on positive pressure ventilation or having pericardial disease, but it's close to be representative of preload with these limitations kept in mind. But one of the other criteria that used to be used for pulmonary hypertension, if you don't have a wedge, is to go with the left ventricular and diastolic volume less than 15 as measurement, or as indicative of a group type 1 pulmonary arterial hypertension. Okay, we're going to conclude it here.
Thank you.
Thank you.
Thank you.